Hello, good afternoon to all those of us here in Ghana. Good morning and good evening to anyone who has joined in from a different time zone. And you are welcome to today's CPD, which is brought to you by Boehringer Ingelheim and International Maritime Hospital. My name is Dr. Becky Apia, and I'll be your moderator for the day. I am a radiologist and the head of imaging and clinical services at International Maritime Hospital. Now, within the next hour, we hope to dissect and learn as much as we can the topic for today, which is in-depth on-target review, optimizing hypertension management. And we have a seasoned, learned colleague of ours to help us achieve this mission. But before I introduce her, permit me to tell you a little bit about International Maritime Hospital, which is a subsidiary of Ghana Ports and Harbours Authority. So this is IMA. We are a 130-bed ultra-modern tertiary hospital with state-of-the-art medical facilities located in the serene environment of Community 3, Tema, and we recently celebrated our 5-year anniversary. Our vision is simple and straightforward: to become the preferred center of excellence in client-focused and specialized healthcare service delivery in the West African sub-region and beyond. Our mission is to offer a one-stop shop referral center that provides international standard healthcare in a customer-centered and congenial environment, endowed with ultra-modern technology, as well as highly dedicated, experienced, motivated, and empathic staff. Now, I'll just take you briefly through some of the scope of services that we have. We have our clinical unit, which has the main medical, surgical, pediatrics, obstetrics, and gynae departments. We have all the various subspecialties, including cardiology, nephrology, endocrinology, dermatology, urology, plastic surgery, urology, etc. This is just an image of our pediatric unit that I wanted you to see. We have an A&E center with ambulance service, and right next to that, we have a cath lab, so a cardiac cath lab. We also have ancillary services like the lab, the pharmacy, and our flagship imaging center, which houses a 3 Tesla MRI machine, the first of its kind in the sub-region. Our theaters are available for all our surgeons to come in and perform whichever case that they are interested in. And we have our lab here showing the lab, our physiotherapy unit. We have our own oxygen plant where we produce oxygen for ourselves and for other facilities. And we also do not discriminate. We have a morgue where our loved ones are given a befitting resting place before their final resting place. Now, coming back to today's topic. There's a slide that I wanted to show you, the last slide. Yes, this slide shows us the top 10 OPD chronic conditions managed at IMA in the year 2022. Now, the highest one was end-stage renal disease, taking a whopping 61%. The next was hypertension, which was 13%. We have diabetes mellitus in there, about 7%. If we just take these three things, we all know that hypertension plays a key role in this. So the disease burden is actually a lot bigger than sometimes represented in our data. So today we're going to have Dr. Abba Folsen. She is a senior physician specialist and consultant cardiologist at International Maritime Hospital, and she's passionate about mentoring younger colleagues. She's passionate about excellence in clinical care and knowledge dissemination through research, and she's going to talk to us on in-depth on-target review, optimizing hypertension management. Before she comes in, quick housekeeping rules. We have a comment box. So if you have any questions, kindly put your questions in the comment box. At the end of her presentation and the second presentation, we're going to go through a Q&A session and all your questions will be answered. Dr. Abba Folsen, you are welcome. Please take over.
Thank you very much, Dr. Apia, for your kind introduction, and thank you everybody for joining us this afternoon where we are, and wherever, whatever the time is, wherever you are, we extend warm greetings to you and thank you for making the time to join us. So today we're talking about hypertension, and as Dr. Apia rightly said, hypertension has become a very key part of our lives currently because um, it is indeed the number one silent risk factor for every imaginable cardiovascular disorder that you can think about. And if you think about it, if you're able to get over hypertension, you'll be able to reduce morbidity and mortality um, in the cardiovascular space in particular by a very significant amount. And prevention indeed is better than cure, especially in our part of the world where a lot of um, end stage or advanced therapies are largely unavailable to most of um, our cherished patients whom we see and whom we'd like to help, but a lot of the time are unable to help. So we're going to spend the next 45 minutes talking a little bit about hypertension, about basic concepts, really, definitions, classifications, pathophysiology, just so that we can orient ourselves about what we are talking about today. But we'll also zone in a little bit into areas that we would usually not talk about, but the effect of the circadian rhythm on blood pressure and other neurohormonal pathways. And then we'll go through how to evaluate our patients and to treat the basic principles that govern treatment of our patients. And as you know, in cardiovascular space, there's a lot of dynamism and research into all the various therapies that we have and which we offer to our patients. But today we're going to focus a little bit on the angiotensin receptor blockers, look a little bit at the data that supports one particular one, which is Telmisartan, and why it has contributed significantly to managing hypertension, more importantly, reducing the morbidity and the mortality that is associated with high blood pressure. So, cardiovascular diseases occur in a continuum, meaning that it usually would have started from one point and then it would progress depending on the exposure to risk factors and other comorbidities to end up in all the target organ diseases that we are hoping ourselves and our loved ones will not come to, some of which include myocardial infarctions and strokes and renal failure and etc. And so, knowing that hypertension is the most important, or at least one of the most important risk factors for these end organ damage, um, it becomes important to be able to define it and to identify it in good time and then to manage it optimally so that with that being managed, you can reduce the risk of developing complications down the line, which is the tail end of the continuum that I mentioned earlier on. So, because of that, we do know that blood pressure does have an effect on endothelial function or on the ability of the endothelial system to respond to hormones, to respond to the sympathetic and the parasympathetic in order to maintain an adequate peripheral resistance and therefore reduce the blood pressure. However, a lot of data has gone into finding out that beyond the particular limit of blood pressure, the risk of not treating is higher than the risk of treating the patient is much lower than the risk of not treating the patient. And therefore, arbitrarily, most societies define hypertension at a systolic blood pressure at or above, or a diastolic blood pressure at and above 90. So 140 over 90, greater than or equal to 140 over 90 as the blood pressure limit at which you kind of want to do something actively, to be able to control it in order to prevent complications. The definition for hypertension, however, that I particularly like is the one that says that it's the level of the blood pressure at which the benefits of treatment, in whichever form that you find to be appropriate at that particular time, that treatment unequivocally outweighs the risks that are associated with the treatments. So the drugs that we give are not totally innocent. But when you compare the risk and the benefit ratios, it far, inches in the direction of therapy. And at that point is where you want to define your patient as being hypertensive. Arbitrarily, for most societies, it is at 140/90. But hypertension has evolved, and then the concept behind managing hypertension has moved beyond numbers to looking at the patient holistically. It's moved beyond bringing the numbers down from 180, 100 to 130, 80, and thinking that as a practitioner you have achieved a lot. It is important to get the numbers down, but now the concept is moving more in the direction of looking at the patient holistically and determining whether, beyond bringing the blood pressure down to 130, 80, is the sugar also controlled? Is the weight down? Has the patient been able to cut back and hopefully stop the smoking? Is the weight appropriate? So it involves a complete and holistic approach that involves looking at all the risk factors that are known to cause cardiovascular disease, in addition to the high blood pressure, which is indeed our focus for today. Having said that, most patients with high blood pressure are said to have essential hypertension. That's to say that there is an underlying genetic predisposition that is brought out or enhanced by the effect of lifestyle that eventually makes the disease to show forth. So as many as 95% or even more patients have essential hypertension, and a small 5% have other disease conditions that lead them to have hypertension, therefore would have to be screened for and then actively managed in order to help to control the patient's blood pressure. But by and large, hypertension, as we know it, is a genetic and a lifestyle disease and requires a look into the diet, a look into the physical inactivity, the stress. I don't know how we're going to get over stress. Work is stressful, economy is stressful, so these things are difficult sometimes, but they must be looked into and addressed appropriately. As I said earlier on, cardiovascular diseases are a continuum, and if you focus on the top part of this semicircle, forget the bottom bit for now, you can see that hypertension begins or is associated with significant atherosclerosis and remodeling, the concept of which we'll talk about subsequently. And the changes in the structure of the heart and the blood vessels because of atherosclerosis is what predisposes patients to myocardial infarctions and stroke. And these changes continue to occur and eventually lead to the tail end of organ disease, such as heart failure, etc., that we are trying to prevent. So it doesn't just happen in one day. It doesn't just happen that a patient gets a myocardial infarction in one day. It's not impossible, but it is largely uncommon. And there must have been warning signs, there must have been predisposing factors, there must have been situations that either the patient or the practitioner may have not focused on and which developed over time and led to the complications that we all try to avoid. I did mention, however, that beyond essential hypertension, which tends to be the commoner variant of hypertension, you have several other disease conditions that are associated with hypertension. And I'll try to mention a few here. The reference here is the European Heart Journal 2004 overview of the most common causes of secondary hypertension. Most of us think that if patients are young and their blood pressures are high, then there must be a secondary cause. I think the more accurate way to look at it would be that in younger patients, there are greater numbers of people who may have secondary causes to the disease. But by and large, essential hypertension is still the commonest reason for hypertension, even in younger people, and therefore genetics and lifestyle still play an important role. But you want to consider other predispositions to hypertension, including obstructive sleep apnea, renal parenchymal diseases. I'm talking about glomerulonephritis, and other tubulointerstitial diseases that lead to high blood pressure. I'm talking about renal artery stenosis, which typically is also part of the whole phenotype of atherosclerosis, but in some younger people may be associated with fibromuscular dysplasia, leading to hypertension. In primary hyperaldosteronism, there's excessive production of aldosterone, leading to excessive absorption of sodium, which is going to affect the blood pressure in ways that we'll talk about subsequently. Thyroid disease is very present in our physicians' clinics, and sometimes we focus a whole lot on hyperthyroidism, but hypothyroidism is also a very important cause of hypertension in that it causes accelerated atherosclerosis. It's associated with excessive levels of dyslipidemia, which fuel this unhealthy pathway and therefore lead to hypertension. Cushing's disease, pheochromocytoma, a little less common, but definitely an important factor to consider. When you see a patient in the consulting room and the blood pressure is high and the potassium is low, you don't want to ignore it. You don't want to think, oh, it was a lab error. The lab may have had an error, but as clinicians, we need to pay attention to certain small details, and which will lead us to make the diagnosis that we need to make, and will lead us to follow through and with further investigations. Right. So how are we going to be able to classify hypertension or an elevated blood pressure? And is it necessary to be able to classify blood pressure into different categories? Over the years, the classification has become a little bit more complex, but it's all because it's become more important to be able to detect the blood pressure earlier. And it is the level at which you detect it that determines the mode of intervention that you're going to apply in managing your patients. I've put here again the ESC 2018 guidelines for the classification of hypertension, which is what we use in Ghana. In our national cardiovascular guidelines, we also make reference to this scale of classifying hypertension. I'd like to mention that because of the concept of managing hypertension holistically, with the overarching aim of reducing morbidity and mortality in our patients as a whole, other communities, such as the Americans, define hypertension a little bit differently, because they realize that when they use the cutoffs that most of the world uses it, because of their extreme other risk factors, they have extreme obesity, extreme use of cigarettes, extreme poor dietary habits. Cumulatively, they develop end organ damage a little bit earlier. And so when they wait to define hypertension at 140/90, it leaves it to be a little too late. And so the Americans define hypertension as starting from 130 systolic over 80, but the rest of the world still uses grade 1 hypertension to be a blood pressure at or above 140/90, but less than 160/100. Before this magic value, there are other ranges in this classification that talks about the optimal blood pressure, which is expected to be less than the arbitrary 120/80 that we all know and love. And then between 120 systolic to 130 and diastolic of between 80 to 85 would be what would generally be termed as an okay blood pressure or a normal blood pressure. When it begins to inch into the high normals, which is about a systolic of 135/85, then in this classification, you want to keep an extra eye out for the patient. This is the point where you want to really determine whether, apart from this almost high blood pressure, do they have other almost high parameters? Are they just a little bit overweight? Is the fasting sugar not actually above 7, but always in the range of 6.7, 6.8, meaning there's impaired fasting glucose or there's some kind of pre-diabetes. Is the diet adequate? Is the patient exercising enough? Are there other worrying risk factors that we typically don't even focus on? Atypical lipids, inflammatory states leading to high inflammatory reactants such as C-reactive protein, high uric acid, all those little things that you would probably have ignored. But in the setting of a high normal blood pressure, you kind of want to consider, because when you put them all together and you look at the risk of your patient for developing complications, it might not be as small as you think by just looking at the blood pressure. So that's the importance of looking at that range. It draws your attention to other risk factors, and that might turn your look or your treatment of the patient in another direction, if you consider it. Apart from that, blood pressures that are above 166 systolic but less than 180, and then above 100 but less than 110 diastolic are graded as hypertension grade 2, and above 180 over 110 is grade 3. And that's like the big stuff where a lot needs to be done, a lot needs to be done quickly. And at that stage, you're not only looking for risk factors such as diabetes, overweight, diet, but you're actually looking to see whether there is evidence of hypertension mediated organ damage. So at that level, and even before then, is the kidney beginning to show signs of damage? Is the retina involved now? Does the patient have carotid artery atherosclerosis? Other things that are beginning to point towards typical organ damage. So that is the rationale behind this busy classification of hypertension, a little bit more detailed than the simplistic way that we used to do it. And that reference was to blood pressures that you would measure in the hospital. So typically, your patient would come see you in the hospital or go to a pharmacy and get their blood pressures checked. But over the years, we found out that a lot of dynamism affects the patient's blood pressure, depending on where it is that the blood pressures are being measured. And so it became important to look at blood pressures measured in other scenarios or in other situations outside of the office, because several different phenotypes of high blood pressure became determined as we began to measure blood pressures outside the office. For example, a patient who is very stressed at work and who is a CEO of a company, or who has a very busy lifestyle, unable to make ends meet, has demands that he needs to make, might be very stressed at home and therefore would have higher blood pressures at home than when he comes to a nice environment such as IMA to see a well-trained, affable clinician. And then the blood pressures would be falsely lowered in that environment. And so you would walk around thinking that, oh, this patient's blood pressures are okay, or they are not as high as they actually are. But at home, when you check, the blood pressures may be as high as 160, 180 systolic, and we'll miss it if we focus just on the office blood pressures. On the contrary, you have some patients who have a little bit of anxiety when they come into the hospital. It doesn't matter how warm or how engaging the facility is. They still get a little bit anxious with medical gadgets and with being around medical personnel, and therefore would have falsely elevated blood pressures, which will warrant or which will lead the clinician to start treatment if we don't look at it properly. And then we'll go home and the blood pressures will drop, or the patient will be exposed to medications unnecessarily. And so for these and many other reasons, it became important to assess the patient's blood pressure outside of the hospital. And in doing so, there are two main categories or main ways by which we assess patients' blood pressures outside of the office. We would use an ambulatory blood pressure monitoring device, which is fixed on the patient's upper arm and programmed to monitor your blood pressure every 30 minutes and store it. And then it will generate values that span three main areas. particularly the daytime average. So daytime is usually defined as from 6 a.m. to 10 p.m. And all the blood pressures that are measured in that period are averaged. And then the nighttime blood pressures are also determined. Nighttime usually defined from 10 p.m. to 6 a.m. And then the 24-hour average is also determined. And depending on what the cutoffs are, hypertension can be determined. The advantage is that this gives you an idea of what the patient's blood pressures are, both when they are with you in the hospital facility and when they are outside of the hospital facility. And it is recommended by most guidelines that the patient should have at least one of these done before they are tagged as being hypertension, so that you can have a holistic picture as to what the patterns of the patient's blood pressure is. And these equipments are largely available. IMA is taking hold of such an equipment very soon, and other facilities may have it. But largely, because it is not so available, we could also use the home blood pressure monitoring system, where a patient has a calibrated, semi-automated machine and checks the blood pressure 2 or 3 times in the morning, 2 or 3 times in the afternoon, in the evening, over a period of time, couple of times a week, and which we can average and use to have an idea about what the patient's blood pressures are outside of the office. This is also important because we're going to talk about the effect of the circadian rhythm on the blood pressure, and what happens to the patient's blood pressures at night also plays a very important role. But having said that, when you do a 24-hour assessment of a patient's blood pressure, there are certain cutoffs that we go by and use to determine this patient as being hypertensive or not. So when you do an ambulatory blood pressure monitoring, the daytime blood pressures, a systolic of above 135/85 during the day, or above 120/70 during the night, or an average 24-hour blood pressure of above 130/80. Or if you're using the home BP monitoring system and your patient's blood pressure of the averages of the BP that they took were above 135/85, then the patient should be considered as being hypertensive and treated appropriately. So I think the take home I want to really put across from here is that you don't measure a patient's blood pressure just once in the hospital and serve medications, because there are a lot of factors that go into the value that you obtain for this patient. Right. So with regards to prevalence, in Ghana recently, a couple of us did a study across 4 regions in Ghana, and it was a community-based study that we used to assess the prevalence of literally all the risk factors for cardiovascular disease. And we also screened these patients for target organ damage, on a population level, like a community-based study. And in that study, we found out that using a cutoff of 140/90, the overall prevalence of hypertension in Ghana as at now is about 26.1%. But the real fun part of this data that we published put across the fact that it wasn't just hypertension that was a problem in the community. Look at the prevalence of dyslipidemia, 34.4%. Look at the prevalence of people who don't exercise more than 150 minutes per week. That is like 85% of the population don't exercise enough in our society. 15% of people like what we call the enough body phenotype. You cannot be slim as a Ghanaian woman. It's not nice, but it is associated with risk factors. It's associated with end organ damage. Diabetes, 6.7%, and diabetes is a really big multi-organ problem. The other thing we noticed in this study was also, typically we would do triglycerides, total cholesterol, LDL in our normal lipid panel, and we base a lot of decisions on that. But we also screened our patients for lipoprotein little a, which is a very uncommon small, high density lipoprotein, which is very atherogenic, actually predisposes patients a whole lot to atherosclerosis. And we found that as many as almost 20% of the population had high lipoprotein little a, and which we were not checking for or considering in our normal assessments. So I think this chart of the study that we did puts together the real need for looking at your high blood pressure patient beyond the numbers. It becomes very important to know whether this patient has a chronic inflammatory state. For example, people who have SLE, people who have retroviral infection, have a chronic inflammatory state. They tend to have high elevated CRP. And as many as 25% of our population had a predominantly high CRP level. CRP is one of the emerging or novel risk factors for cardiovascular disease. So I think what I want to put across is that if you focus on just the blood pressure, you'll be doing your patients a disservice. It becomes important to look at your patients holistically in order to help them to live much longer. Worldwide, the global average for the prevalence is about 22%. So about a fifth of the world has hypertension. A fifth of the world is at an increased risk of every imaginable cardiovascular disease. And we do know, of course, that the prevalence of hypertension increases with age. And so as you're growing older, the prevalence increases. But if you look at the sex differences, you realize that the male sex tends to have a higher blood pressure in the younger age, less than 50. So because the women have the estrogen protection that leads to adequate vascular function, reduction in peripheral resistance, etc. And so that's good for us in that era. But then strikingly, as we hit menopause and begin to grow, then the prevalence begins to increase over and above what the males have, because that protection is lost. And therefore, it means that the menopausal woman sitting before you must be looked at critically, and managed and screened adequately so that she's likely to live longer. So in understanding how to treat hypertension and how it causes the damage that it's known to have, it's important to understand pathophysiology. There isn't a presentation that I do that I don't talk about pathophysiology, because it is the bedrock of understanding why you would do things the way you do. So generally, we know that the blood pressure of a patient is dependent on two very important hemodynamic parameters: the cardiac output and the peripheral resistance. Cardiac output, peripheral resistance, the product of which determines your blood pressure. And the cardiac output is determined by your heart rate and your stroke volume. So in effect, your blood pressure is dependent on what kind of heart rate you have, what kind of stroke volume you have, which is the amount of blood that is able to move out of your heart with every contraction. And then the peripheral resistance, which is the blockade or the resistance that the blood vessels, typically the arterioles and the arteries, are offering to the flow of blood out of the heart. So largely, if your peripheral resistance is high, your blood pressure will be high. Peripheral resistance is determined by several factors, and some of these are transient or temporary. But these temporary factors eventually give way to more permanent increase in peripheral resistance, and that affects the patient's blood pressure. So looking at it in a bit more detail on this, and never mind the busy slide, I think I'll be able to simplify it very easily. We said already that the blood pressure is a product of your cardiac output and your peripheral resistance. Your cardiac output is determined by your stroke volume and your heart rate. Your heart rate is determined by several factors, among which include your sympathetics. So if you have a condition that is increasing your sympathetic drive, such as hyperthyroidism, such as anemia, such as pheochromocytoma, then you have persistently increased heart rate, and that affects your blood pressure. If you have an increase in your stroke volume is determined a lot by your preload, which is the amount of blood that fills the heart during relaxation. And then that is determined a whole lot by sodium and water. So if you have a situation where there's excess salt and water absorption or retention, then the stroke volume will increase, and as a consequence, your blood pressures will also increase. In Ghana, we like salt. Our food is heavily salt dependent. We like Kobe in our contemporary stew. And it doesn't help. It doesn't help. All right. Apart from that, so these changes usually occur and maintain a certain level of vasoconstriction, an increase in peripheral resistance, an increased preload. But with progressive damage to the blood vessels and progressive atherosclerosis, you have endothelial dysfunction and you have remodeling or permanent changes in the structure of the blood vessels, which lead to persistent fibrosis or persistent state of constriction, which therefore really increase your peripheral resistance and affect your blood pressure. So that's what I talked about, the initial functional constriction that occurs because of RAS activation, salt and water retention, angiotensin 2 and aldosterone production, vasoconstriction. We know that pathophysiology. But beyond that, atherosclerosis leads to structural changes. The aldosterone and angiotensin 2 that are produced lead to structural changes, irreversible changes in the blood vessel and the cardiac myocardium, that leads to persistently increased peripheral resistance and then high blood pressure. Generally, your blood pressure fluctuates. We know that it is influenced by several things, including caffeine intake, level of stress, whether you are sitting or standing, whether you're lying. But for the purpose of today's presentation, I want to talk about the circadian rhythm and its control on the blood pressure. So generally, you know that during the daytime, because of increased sympathetic activity and influence on our basal metabolism, there is a higher blood pressure than in the night, where we are at rest and the parasympathetic activity is increased, and which drops the blood pressure in the night. So it is expected that as you're sleeping, your blood pressure drops by about 15 to 20% of what your normal daytime blood pressure is. And that is physiology. And this physiology is important. But there are some patients or group of patients in whom that normal physiological dip does not occur. And by the same mechanisms that does not occur, there is an abnormal increase in the blood pressure in the early morning hours. So we talk about the non-dippers, are the ones whose blood pressures don't dip appropriately in the night or in the night to the dawn period. And then there are the ones whose blood pressures shoot up unnecessarily in the early morning, which we call the early morning surge. I'm sure a lot of you have had patients who come in, you look at their BP profile, and you realize that in the mornings, their blood pressures are higher than during the day or even in the evening. And those are the ones who have an early morning surge. And this abnormality in the circadian rhythm is fueled by several factors, some of which include, I think I deleted that slide, sympathetic overdrive, inadequate vagal tone, obstructive sleep apnea, hormonal imbalances, all of which predispose to your inability to drop your BP at night and to maintain it at a sensible level in the early morning. The third thing is that this phenotype of non-dipping or early morning surge is particularly associated with cardiovascular events. And that's why it becomes important to monitor your patient's blood pressures over a 24-hour period, because you wouldn't know some of these phenotypes until you search actively for them. But it's been found out that patients who have an early morning surge in particular have an associated increase in myocardial infarctions and strokes and etc. And there are different ways by which we are able to assess whether you have an early morning surge or you are a non-dipper. Clearly, if you do an ambulatory blood pressure monitoring and we look at your nighttime recordings and your nighttime BPs are persistently um, elevated, 140, 90, 150, 100 in the night, then you are not dipping adequately. So by and large, we can talk about that. And there are different ways by which we assess the early morning surge. So I won't go into the details of it, but I've put it there. We look at the pre-awakening morning surge and the sleep trough morning surge. Whatever it is, we compare your blood pressure just before you are about to wake up, as monitored during the ambulatory blood pressure monitoring, to the first BPs that you measure when you wake up. And then we look at the difference in the two, and we're able to determine whether you have an early morning surge or not. Apart from the blood pressure, the circadian rhythm affects other hemodynamic parameters. And this is important to note. So pardon me for belaboring the point, but it becomes important. So you're expected to drop your heart rate by about 10% because of the increased vagal tone, your peripheral resistance, your cardiac output, your GFR are all supposed to drop during the nighttime period. And if this does not occur, then you are at an increased risk of cardiovascular disease. And as I've put there, it's been found that 40% higher relative risk of an MI occurs in people who are non-dippers. So you realize that a lot of MIs occur in the night and at dawn and in the early morning. And that is thought to be one of the reasons why patients who have non-dipping or early morning surge may present in the early hours. Strokes occur in the early hours. Patients will typically say, I woke up to go and wee in the night, and then that was the beginning of the stroke. So these have been documented to be associated with increased cardiovascular risk. Oh, I put it there. So these are the factors that lead you to have early morning surges, sympathetic overdrive, oxidative stress and free radical release, fueling endothelial dysfunction, accelerating it, and making your plaque more unstable and more likely to rupture, leading to that MI or that hemorrhagic stroke. Right. Okay, so we've understood what the high blood pressure is. We've understood how to categorize it. We've understood certain parts of monitoring and what the values should mean to us. But when the patient sits before you and you're managing the patient, there are important factors that you need to consider when you are evaluating them. The patient sits before you, you've measured the blood pressure, you've done the ambulatory blood pressure monitoring, you're quite sure this patient is hypertensive. So what? Is it enough to just serve some antihypertensives and bring the blood pressure down? Probably not. We need to evaluate the patient. And in doing so, we are trying to establish the diagnosis, like we've talked about already, and grade the hypertension. We're going to screen for potential secondary causes if it is necessary. I'd like to pause here and mention that it's not just because the patient is 27 and presenting with hypertension that we should do all kinds of tests for secondary hypertension. As a list of causes of hypertension, secondary hypertension, you can't do all of them. It's not cost effective. So you need to do a good history and a good physical to be able to see which of the secondary causes are more likely to be present in your patient. So a patient sitting before you who has an obvious anterior neck swelling, you need to delve into that. A patient who has a buffalo hump, you need to look into the cortisol. A patient who tells you, my BP goes high, I'm sweating profusely, and then the BP will drop, you need to look into the few. So the history and the physical exam will guide you as to how extensively your search for a secondary cause should go. And then you should identify potentially important factors that are contributing to the high blood pressure. So this patient is leading a stressful life. Are they getting enough sleep? Is there smoking? Are they drinking excessively? Illicit use of stimulant drugs, cocaine, etc., which are sympathomimetic. Are all these factors going to affect this patient sitting before you? It becomes important to know. Then you want to screen the patient for other risk factors. I showed you the data here in Ghana, where a lot of our patients have high cholesterol, high sugars, high this and high that, and they must be looked for actively and managed just as importantly as the blood pressure be managed. And then ultimately, you need to look whether there's evidence of organ involvement already. So the patient BP just high, or now they have grade 3 hypertension, retinopathy, or do they have early renal dysfunction, or do they have concentric left ventricular hypertrophy already occurring? And that is what I really want to say as far as holistically looking at the patient with hypertension is concerned. I think this is a little more detailed about what I said as far as what to look for in your history and exam is concerned. I think most of us are aware of it. So I will not belabor the point, but you should go into the dietary history. You should go into how much fruit and vegetable they take, how much alcohol they are drinking, how much Kobe plus ordinary salt they put into the contemporary stew, how much work they are able to do, how mobile they are, any other symptoms that are going to suggest organ involvement. Do they tend to get blurred vision? Have they had weakness on one side before? Do they get some funny chest pain when they get angry? Do they intermittently get breathless? Then you know that other organs are beginning to get involved. Are they getting pedal edema? Are they getting claudication? So when claudication is one of the things that we tend to miss because we attribute a lot of the leg pain to neuropathies and osteoarthritis and other things, but forget that peripheral artery disease forms part of the continuum of cardiovascular diseases, and the biggest risk factor is indeed hypertension. And so we should look for claudication. We must examine the extremities, we must feel for the pulses, and then make the diagnosis as and when they present to us. And when you've done this evaluation using the history and exam, then you need to evaluate using investigations to try and look for certain risk factors that you're thinking the patient may have, or to look for evidence of what we call hypertension-mediated organ damage. So basically, when a patient has hypertension, you've taken a history and exam, and note carefully, I'm emphasizing on history and physical exam. Then you need to do a few routine basic tests. Check the hemoglobin. For example, anemia puts the heart into overdrive and fuels the remodeling. You need to correct it. Anemia could be one of your early indicators of renal involvement in a patient with hypertension. And so we must pick it up early. You must check the patient's fasting sugar and not stop there. You must do the A1C, because there are patients who have impaired glucose tolerance and their fasting sugars are okay. And you will miss the patient who has some kind of pre-diabetic state if you look just at the fasting sugar. Blood lipids are important. And I'd like to make a comment here about blood lipids, that the reference ranges that the lab gives us are a good guide, but the reference ranges largely don't apply and must be used in reference to the patient who sits before you, because the target LDL that you want your patient to get to is very dependent on your patient's risk as you've stratified. I couldn't add risk stratification to my talk. It was going to be too lengthy, but you need to assess your patients and grade them as low risk, intermediate risk, high risk, very high risk. And depending on which risk category that they are in, the target for the lipids, they vary. And so you may be managing the BP very well, but if you don't attack the cholesterol just as well and you're looking at the reference ranges from the lab, then the care is not optimal. You want to do a renal function test. You want to keep an eye on that potassium. You want to look at the urine, the creatinine, and the EGFR. And you really want to pick up renal impairment before the creatinine begins to go high, because at that point, then a lot has already occurred that may be very difficult to reverse. One of my favorite teachers, Professor Fram, he says you can't assess the kidney of a patient without looking at the urine, because the urine tells a whole lot about what's going on in the kidney. So you want to do a normal dipstick, which is going to tell you about proteinuria and red cell casts and etc. But even before then, you want to do a urine albumin creatinine ratio, which is very important way of assessing proteinuria, and particularly microalbuminuria, which the dipstick probably will not pick, because the quantity of albumin within the urine at that time is not able to be picked by the normal dipsticks that we use. So you want to assess albumin level in relation to creatinine within the urine. And that tells you about very early microalbuminuria. That's one of the early warning signs of renal impairment. Of course, you need to do a 12-lead ECG, which is going to tell you about all kinds of things, really, about chamber dilatation, about left ventricular hypertrophy, about complications that may have occurred already, arrhythmias such as atrial fibrillation because of hypertension, ischemia, etc. So the ECG is an invaluable screening tool in assessing for cardiovascular disease related to hypertension in particular. But after these initial tests, then you would want to consider other tests depending on what these tests would point out. So if you think the patient has a secondary cause of the high blood pressure, then you want to do specific tests to look for those. You want to look at the cortisol levels, the thyroid function tests, the urine metanephrines, etc. You want to look in the eye of the patient. Actually, that's not a special test. That's something you should do routinely, at least once a year for your patients. And then, of course, ultimately, you should do the echo, because that gives you visual appreciation of what is actually going on in the heart. We know that the ECG has issues with specificity as far as LVH is concerned, and therefore you're able to actually look at the heart in echo, pick up those wall motion abnormalities, look for complications that may have occurred. So these tests are an add-on to the initial preliminary ones, which should be done for all hypertensive patients. So once you've evaluated this patient and you've made the diagnosis and the mode of treatment is very dependent on where the patient's blood pressure is at, how you graded the hypertension. Was it high normal hypertension? Was it grade 1, 2, or 3? Because the therapy to institute is very dependent on that. And so we realize that lifestyle modification forms the bedrock of treating every patient who has some kind of derangement in their blood pressures. And the lifestyle modifications include, I'll mention those later. And then, so for the high normals, remember I told you that is like the warning sign where you should consider lifestyle, you should institute lifestyle advice and screen for other risk factors that the patient may have. And you may consider pharmacotherapy if the patient comes in with some evidence of a complication. You find a stroke patient whose blood pressure is persistently 139/89. So it's not fantastically high, but the patient has had a stroke. And so you need to keep that blood pressure lower. And then you need to make sure that his cholesterol is good, his weight is good, he stops the smoking, the sugar is fine, he's eating right. That would be the bedrock of therapy. Then in grade 1 hypertension, again, once the patient has come in with high blood pressure, less than 160/100, but there's LVH, or there's elevated urine albumin creatinine ratio, or there's evidence of retinopathy, then definitely you must institute drug therapy immediately in addition to lifestyle modification. But in those patients who come in with BPs 145, 92-ish, they're otherwise okay, you screen them, they have no end organ damage, they have no real risk factors. When you risk stratify them, they have low risk. Then you can try to do just lifestyle modification for about 3 to 6 months and watch to see whether this happens. We know from experience that a lot of patients are not able to do well on just lifestyle. We like the things that we are not supposed to like too much, and we are unable to let go of them enough to use that alone as a means of treating our patients. As for grade 2 hypertension and above, definitely the patient should be on pharmacotherapy. Indeed, when you're treating a patient with hypertension, you need to consider the target that you are aiming for. It becomes very important because the benefit to your patient is maximized when you achieve target. For most patients who have no end organ damage, blood pressure is less than 140/90 will be acceptable. But for every patient who has any evidence of any organ involved, a mild LVH, a renal impairment, ischemic heart disease, we've had a stroke before, whatever, if there's any evidence of organ involvement, then the blood pressure should be aimed at ending up less than 130/80. So when you have the patient's BP at 180/120 and you do very well, you bring it down to 149 or 150/92, you've done well, but you must keep the goal in sight. You must keep the target in sight. And that's what maximizes the benefit that your patients will derive. You must get there. And we should not, as clinicians, be dissuaded by, oh, yesterday I didn't sleep early, that's why my BP is high. I just came in and the BP was checked. Patients have the tendency to give all kinds of excuses that lead to physician inertia. So you don't optimize the therapy the way you should. And at that level, the damage still goes on. Okay. Again, keeping the targets in mind. If you diagnose a patient with grade 2 or grade 3 hypertension, and the blood pressure at the beginning is more than 20 systolic over 10 diastolic above the target you are hoping to achieve. For example, you diagnose the patient's blood pressure at 170/90 or 170/100. And for this patient, you are aiming at, even if it's 140/90, then you are about 30 and something diastolic above the target you're hoping to achieve. And for that patient, you need to start on at least 2 therapies, 2 drugs, in addition to the lifestyle, because it's been shown that one drug will not get there, and eventually you might never add the second drug if you don't add it from the beginning. So it's recommended that at those levels, we start with at least 2 medications in addition to lifestyle, preferably in a single pill combination. Okay, so that is going to enhance compliance of the patient, and the drugs together are going to have a synergistic effect that's going to optimize the blood pressure control. And so for grade 2, grade 3, you will probably need to start 2 drugs at the same time, in addition to lifestyle, and then together as one pill. Okay. So a brief on non-pharmacological therapy, and we gloss over it, but non-pharmacological therapy is so important in the management. If you're giving a patient a diuretic, which is supposed to excrete sodium and reduce stroke volume so that blood pressures will drop, and this patient is still eating large amounts of salt, kebab spices with salt inside it, canned food preserved with salt, then the drug will not work as optimally and the outcomes will not be good. So these things work together with the drug therapy to improve the outcomes for our patients. And generally, we want to restrict salt to less than 10 grams per day. It's always very difficult to quantify what 5 grams is. But I always say, tell your patient, if you're eating rice and contour stew, I say contour stew like 3 times. Evidently, that's one of my favorite dishes. But if you're eating that meal, you can put a little bit of salt in the rice or in the contour and don't put it in the other one. So you would have cut back on the salt intake, and that really is what we are trying to encourage our patients to do. So don't cut it here and compensate it in the other one. We don't encourage that. But if you're able to exclude using rice to cook, salt to cook your rice, and you use the same amount in your stew or soup, then you would have found some reduction, which is going to help. It's recommended that you cut back on alcohol intake. A glass of wine with your meal a day is acceptable. Anything more than that might not have cardiovascular benefit. Increased consumption of fruits and vegetables, low consumption of red meat, and low consumption of low fat dairy products, or higher intake of low fat dairy products are recommended. So in Ghana, again, how do we make it practical? The vegetables are there, the fruits are there. Patients should be encouraged to eat it. Patients should be encouraged to substitute these fruits and vegetables when they get home late and they are hungry. Have a bowl of oats, which has high fiber, more than having the other thing that was prepared and which doesn't have as much fiber. So we must encourage them to do these. Weight control in Africa is a problem. We like the weight. We're not willing to do what we should do to cut back on the weight. But we must encourage our patients to exercise and to watch the quantity of food that we eat and the quality of the food that we eat. Physical activity cannot be overemphasized. Smoking is not so much our problem here, thankfully. But the other bit here that I'd like to emphasize is education. Education, I find it to be important, non-pharmacological therapy, because, you see, in treating our patients, we are faced with a lot of competition. The herbal practitioners who are saying that our medications are chemicals and theirs is the natural one. The perception about your side effects, the erectile dysfunction that the men are afraid of. Just say the side effects that are so many that people are reluctant to take and stay on orthodox medication, requires that as an orthodox practitioner, you must educate your patient on the drug. You must educate them on the effect of the drug. You must educate them about possible side effects of the drug. You must educate them on non-pharmacological therapy so that the outcomes are better. It is so, so important. Mainly, the 5 main classes of medications that we use to treat high blood pressure include the ACE inhibitors and the ARBs, calcium channel blockers, diuretics, and the beta blockers. And these have proven benefits not just for BP control, but for reduced morbidity and mortality. I think that to save myself some time, I'm going to skip this and then summarize my initial part of my presentation with this small case presentation. I'll spend the next 7 minutes talking about one particular group of antihypertensives and why it has made a mark in our armamentarium. Okay, so 39-year-old presents with headaches for the past 3 weeks to the consulting room. The BP at home was found to be 150, 100 on just 2 occasions. The patient presents before you. What are some of the things you want to consider? Firstly, is this hypertension? You can only answer that by assessing the patient's blood pressure in and out of the office to determine whether this is indeed hypertension or there's some transient reason why the BPs were high. Is there a secondary cause? That's a legitimate question because this is a young person. So you want to look for that in your history and exam and investigate appropriately. Is it just the high blood pressure he has, or does he have impaired fasting glucose, impaired glucose tolerance? Is he obese? Is there any organ-mediated damage already? Does he already have retinopathy? Does he already have an elevated urine albumin creatinine ratio? Does he already have LVH? These are things you want to look into. And then what will be the appropriate modes of treating this patient? You need to emphasize on education, which I've mentioned, earlier on. I mean, I want to see you try and convince this 39-year-old that he's hypertensive and he's going to have to take amlodipine for the rest of his life when he's heard that amlodipine causes erectile dysfunction. That's where our job really as clinicians come in, and education is very, very important. We'll spend the next few slides talking a little bit about the angiotensin receptor blockers. I mean, I know that of all the drugs that we use to treat hypertension as a whole, there's a lot of data that backs it. But for today, we want to look at the impact of angiotensin receptor blockers on our patients with high blood pressure. Basically, we know that their mechanism of action is to inhibit the conversion of, inhibit the activity of angiotensin 2, which acts by binding to the AT1 receptors in blood vessels in particular, and stimulating smooth muscle constriction and vasoconstriction. That's going to lead to increased peripheral resistance and high blood pressure. And so if you're able to inhibit the effect of this drug, or the effect of angiotensin 2 on these blood vessels and indeed on the heart and on the whole cardiovascular system, then you're able to reduce the blood pressure significantly. Indeed, when you do block angiotensin 2's activity on the AT1 receptor, it releases the angiotensin 2 to bind to and activate angiotensin 2, which has sort of the opposite effect. So it will lead to vasodilatation, which we like, natriuresis, which is going to cause salt and water loss, which is good for hypertension, tissue regeneration, etc., and all the other inappropriate cell growth activation that's going to lead to remodeling, LVH, and eventual structural abnormalities. So that, in a nutshell, is how the angiotensin 2 work, and their large effect, or the large effect of the angiotensin 2 as a molecule, is actually not good. You don't want a situation where the RAS system has been overstimulated to the point where angiotensin 2 is in excess, because it leads to all these abnormal inflammatory and tissue abnormalities that worsen the patient's outcome. It leads to release of free radical production that's going to damage the endothelium. The endothelium will not be able to respond to nitric oxide and relax, and therefore the peripheral resistance will increase. Atherosclerosis will be accelerated, and your patient's outcomes will be poorer. So it becomes very important that RAS inhibiting medication be a part of our patients' medications as much as possible. In the past, they used to say that Black people were poorly responsive to RAS inhibiting drugs because we were hyporeninemic. We didn't produce too much renin. And so that pathway was not too active in us. But the paradigm has changed, that even though it is more active in the Caucasians, inhibiting it in our population inures to our benefit, because it reverses all these abnormal pathways and inflammatory processes that I've mentioned. The ARBs in particular, are they different? I mean, after all, they are all going to bind to the angiotensin or the AT1 receptor and have their effect. But are there intrinsic differences? And yes, there are. Most of them do have the effect of blood pressure reduction, which we want. But remember, I spoke to you earlier on about the morning surge. And you realize that most of our patients take their medications in the morning. So by the end of the day, just before they take the other pill, that would probably be the lowest MIC of the drug in our system. And so the lowest antihypertensive effect will be felt probably just before the waking hours of the day. So you want drugs that have a proper 24-hour coverage. And that's going to make sure that even during the nocturnal period and the early morning surge, the drug is available to control the blood pressures. And because of the peculiar pharmacokinetics of Telmisartan, it does have that benefit. So basically, it has a reversible but insurmountable binding to the AT1 receptor. So it binds to it, you can remove it, but it's very difficult to displace it once it binds. And it has such a great affinity for this receptor because of the structure of it. And then it has minimal affinity for the AT2 receptor, which is a good thing. So it releases the angiotensin 2 to bind to the AT2 receptor and then have the vasodilatory effects that we like, whilst it binds the AT1 receptor and prevents vasoconstriction and remodeling, which we don't like. Telmisartan is very lipophilic. Lipophilic drugs are good. They are easily absorbed. They get into the cell quickly through the cell membrane, and they have a rapid and effective onset of action. Most of the ARBs are excreted in the kidney, and so in very severe kidney disease, you want to be cautious about using them. But in the case of telmisartan, it is predominantly excreted by the liver in the feces, and therefore it does not tend to accumulate in patients who have severe renal disease, even though caution should still be exercised in using it. It has a very long terminal half-life and therefore works for a very long period, much longer than most of the medications that are in its class. And because of that, it has profound effects on the blood pressure and is able to significantly drop and sustain, emphasis on drop and sustain, a reduced blood pressure in most of our patients, especially in those critical early morning hours where there might be the surge. Telmisartan has other effects. I'll mention them as we go on, but particularly it partially modulates the PPAR gamma receptor. The PPAR gamma receptor is an important receptor that, when stimulated, has anti-inflammatory and antioxidative, anti-lipid effects, and therefore beyond blood pressure control, telmisartan has important effects on insulin levels, for example, sugar levels, for example, lipid levels, for example, and I'll show you some data on that before I end. Okay. So in looking at ABPM values for early morning blood pressures, studies were conducted among several of the ARBs put together. It was compared head to head the effect of blood pressure control during the early morning period. And losartan, valsartan, amlodipine, and telmisartan were compared. And in that study, telmisartan had the most profound effect in dropping the early morning, reducing the risk of the early morning surge, very likely because of its very long duration of action. Again, in another study, and this was a meta-analysis, put together a large number of patients and was reported on to find the total cardiovascular events or the risk of developing cardiovascular events over time. And it was found that amongst them, the ARBs all had a reduction in the risk of developing cardiovascular diseases. So they all work. However, people who were on the ARBs were less likely to become non-compliant because the side effect profile of the ARBs as a whole were better compared to the ACE inhibitors. So the patients were more likely to comply than in those who were on ACE, even though all of them showed benefits as far as outcomes were concerned. Telmisartan in combination with other medications. Remember, I told you that in this era, we recommend combination therapy, preferably single pill combination therapy in patients who are grade 2 hypertension and above, because they have synergistic effect. And again, when you compared a combination of telmisartan and hydrochlorothiazide compared to losartan and hydrochlorothiazide, then again, the early morning surges were much more reduced in the patients who had 80 milligrams telmisartan compared to those who had losartan and lower doses of telmisartan. So the higher doses had higher benefits, even though all the antihypertensives had some benefit. Similar studies were compared between valsartan in hydrochlorothiazide and then telmisartan and then the reduction in blood pressures as a whole were more sustained and more profound in the telmisartan hydrochlorothiazide group compared to valsartan, which has a shorter duration of action. So telmisartan in particular has a unique efficacy as far as early morning blood pressure reduction is concerned, and the data and the studies are the ones I showed earlier on. There are a whole lot more that show that. It was overall also better tolerated because of a lower side effect profile. We all know that the ACE inhibitors in particular cause dry coughing, angioedema, etc. But that profile was much better in the patients who were on ARBs, and particularly the evidence for telmisartan has been put across. What about renal protection and the effect of telmisartan on the kidney? Again, telmisartan compared to hydrochlorothiazide. Of course, we know that generally the ACEs and the ARBs have better renal protection and slow down renal damage compared to all the other groups of drugs. And in this study, as you compared hydrochlorothiazide to telmisartan, not only was there a significant change in the blood pressure, but there was also a profound change in the urine albumin excretion, which was significantly reduced in the telmisartan group compared to the amount of reduction in the hydrochlorothiazide group, even though both of the drugs had a significant or comparable reduction in blood pressure reduction. The protection of the kidney was seen more for patients who were on telmisartan than hydrochlorothiazide, emphasizing again the fact that it's beyond controlling the BP. The BP might come down, but are you protecting your patients against kidney disease, against left ventricular hypertrophy, against other cardiovascular diseases? That really is the point we are trying to get to. And in this study, again, in diabetics in particular, when they compared telmisartan in different doses to placebo, of course, there was a very statistically significant reduction in progression to overt or frank hypertensive nephropathy compared to those who were not on an on an ARB at all. And so again, it buttresses the point that even though we are Black patients, it's important to incorporate RAS inhibiting drugs with long action and tolerability in our medication list. I'm ending in a few minutes. Cardiovascular and renal composite endpoints of end-stage renal disease, myocardial infarction, hospitalization, again, compared head-to-head, showed a slight increase, which was statistically significant, in the patients who were on telmisartan compared to losartan. So to put it in simple terms, the risk of developing a composite of myocardial infarction, stroke, hospitalization was significantly reduced in patients who were or were on telmisartan compared to losartan. This was done by very seasoned researchers. This was done by Professor George Bakris. He's one of the people who drafted the guidelines, for hypertension management. So these are seasoned researchers, and the data is credible. What about left ventricular hypertrophy regression? If you compare BP control, hydrochlorothiazide will bring the BPs down. Telmisartan will too. But at the baseline, what happens to the left ventricular hypertrophy? In this particular study, you find that at the baseline, the LVH reduction was much more pronounced in patients who were on telmisartan than those who were on just hydrochlorothiazide. And so there's a benefit in incorporating these drugs into our current therapies. What about arterial wall stiffness? Remember, I told you that wall thickening or remodeling is what leads to increase in peripheral resistance and worsening of BP control, and invariably the outcomes. And we find out that there's a significant drop in wall stiffness or wall thickening when we put patients on ARBs, in particular in this study, telmisartan significantly reduced flow velocities within vessels. So imagine this. If you have a vessel that is narrowed, flow through it will be increased when you measure velocities in the vessel. And when you give medications and you monitor, once relaxation begins to occur and remodeling is slowed down, the flow velocities through the lumen will reduce because the narrowing has improved. And this was studied in the carotid arteries and the femoral arteries of patients who were on telmisartan and those who weren't. And that was found to be beneficial in improving flow through the vessels. The other important effect, which I mentioned about the telmisartan in particular, was its selective modulation of the PPAR that leads to, in addition to blood pressure control, improved sugar control, improvement in circulating insulin because of insulin resistance, improved hypertriglyceridemia, and an overall increase in the cholesterol profile because of its additional effect on this particular receptor. And there's data to show that telmisartan significantly impacts on fasting plasma insulin level reduction, blood glucose levels, and then triglyceride levels as well. Oh. I think my slide is not moving. Right, thank you very much. So the last slide, before I summarize, is this study that was compared between telmisartan and nifedipine as far as LDL cholesterol was concerned. And we realized that its impact on controlling lipids in the setting of hypertension was greater than in patients who were on nifedipine, which is a calcium channel blocker. So I'm putting this slide up again, but this time I'm looking at it from a different angle. Initially, I used it to talk about the cardiovascular continuum, but now I'm using it to show all the different trials that have been done on the different aspects of the continuum involving telmisartan and how it impacts and improves or slows down the progression towards end-stage renal disease. And all these studies were done to look at different aspects of the cardiovascular disease, but using telmisartan. So for every stage of this continuum, telmisartan in particular has data to show its impact and influence in slowing down and reversing these various components, including remodeling, the risk of an MI, progression of atherosclerosis, cardiovascular remodeling, etc. And I think this is a summary of what the trials looked at, the different trials with telmisartan. In this particular data, that we're supposed to focus a whole lot on the ONTARGET, but I decided to do a bit of an overview on the varied effects of telmisartan, apart from the ONTARGET trial, which was looking at comparing telmisartan and Ramipril as far as vascular disease was concerned, and was found to be superior in them. So in summarizing, today I've tried to talk basically and to put across the fact that hypertension forms part of the whole cardiovascular disease continuum, and it should not be looked at in isolation. It becomes very important to consider that not just controlling the hypertension will do the trick, but understanding that this hypertensive patient before you also has other cardiovascular risks that you must actively look for and optimally manage in an attempt to reduce their risk of morbidity and mortality. And when choosing antihypertensive therapy, it's important to consider the medications that inhibit the renin-angiotensin or aldosterone system, and which have benefits for the patient beyond blood pressure control. We've looked at telmisartan and the benefit it brings to the table as far as metabolic control is concerned, as far as LVH is concerned, as far as proteinuria is concerned, as far as renal impairment is concerned. And I think it becomes an important molecule to consider when we are managing our patients with hypertension. I'm sorry, I've gone a little bit over my time, but I'll keep quiet now and wait for questions. Thank you. Over to you, Dr. Apia.
Thank you very much, Dr. Abafolson, for such an in-depth review. I learned so much from your presentation, and your summary also said it all. Thank you all for listening in to. At the moment, we have over 273 individuals in this live session, and we are still reminded to put our questions in the comment box. Next, we're going to have Mr. Stephen Colley give a very short presentation. He is a pharmacist and medical representative from Boehringer Ingelheim. He is going to speak to us on myocarditis twin star dosing and availability. And after that, we'll have the Q&A session. Thank you very much. Farm Stephen, over to you.
Thank you very much. Thank you very much, Dr. Apia. And also thank you very much, Dr. Folsom, for such an immense and wonderful presentation. So I'll start very quickly. The slides, please. So my presentation is very straightforward. Basically talk about the availability of myocarditis. So Telmisartan was developed by Boehringer Ingelheim, and we call it myocarditis. And what myocarditis gives you is basically to achieve sustained blood pressure control beyond 24 hours in a once daily formulation, as well as provide additional benefits, in particular CV protection and placebo-like safety and tolerability. Now, myocarditis is available in many forms. We have a few combinations. First, we have the monotherapy, which is myocarditis, just Telmisartan 40 milligram and 80 milligram. Then we have a combination with hydrochlorothiazide, which is co-myocarditis 12.5 and co-myocarditis 80-12.5. We also have another combination with amlodipine, which is called twin star, which is twin star 85 milligram and twin star 80-10 milligram. So this is a combination we have with amlodipine, and basically this combination gives you more in terms of blood pressure control. So just a few summarization about concerning what you are really going to get with myocarditis for your patient. So myocarditis is a unique ARB with a unique structure, giving it the longest half-life in the class, highest volume of distribution, and also the lowest renal excretion. It also offers quick and powerful blood pressure control as compared to other ARBs. It's also the only FDA and the European Medicines Agency's approved ARB for CV protection in terms of reducing the tendencies for strokes and other CV events. It also provides additional end organ protection beyond blood pressure control. Now the goal here is just not to control the patient, but also to provide organ protection and reduce the risk of other cardiovascular events taking over. It is safe and well tolerated. So twin stars, I stated earlier, offers powerful blood pressure control, up to 50 millimeters of mercury in terms of reductions. Also, the power of twin star once daily lasts a full 24 hours. Now, this combination with amlodipine, imagine very strong blood pressure controls, especially in the early morning hours. And as we heard from Dr. Folsom, this is very, very important for patients who are at risk of early morning blood pressure surges. It also provides powerful blood pressure reductions needed to get your added risk patients to goal. Twin star also contains Telmisartan, which I explained earlier, the CV protection it gives. It is also safe and well tolerated, as we also heard from Dr. Folsom. So in terms of availability, our main distributors are NS Chemist, Ozon's Chemist. Now, in terms of retails and wholesales, we like to say myocarditis, co-myocarditis, and Twinstar are readily available in all leading pharmacies across the country, from the top to the bottom, east to the west. You can readily find Mycardis, Co-Mycardis, or Twinstar for your patients who may really need the medication. So this is something we've made sure it's readily available, and in some facilities, they're actually well stocked, and for some of your patients, they can readily get it at your facilities, and we are quite sure about this. So what we are trying to say is with Mycardis, Co-Mycardis, and Twinstar, what you can see is strong 24 hours blood pressure reduction. But what you can have beyond that, what you can't really see, but your patients are sure to experience a strong organ protection and also better treatment compliance. Thank you very much. And again, it's readily available for your patients on the market.
Thank you so much, Stephen. That was really short and straight to the point. So we have time for the Q&A session, and we'll pull up some questions from the chat box, and then our presenters, our facilitators can answer them. Okay. So the first question is it safe to put patients on long-time aspirin 75 milligram, considering the effects of NSAIDs on the kidneys? And this is from Yaufusu Mensa. Dr. Folsen, if you can take this.
All right, so yeah, that's a valid question. I think that we know the effect of NSAIDs on the kidney. That's why in the past, where the recommendation was to put all patients on aspirin for cardiovascular protection, is over. Now, the recommendation is to assess the patient's risk and determine whether the addition of aspirin to their group of medications will help reduce their risk or not. Because if the risk is not high and you put the patient on it, then like you said, the renal adverse effects are real, and we should avoid putting patients on aspirin just because it's been said to be to increase or reduce cardiovascular diseases. Now, it is considered when there's a clear indication the patient has had an MI, infarctive stroke, blah, 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 or the patient hasn't had these, but you do a risk assessment, the patient has a high risk for developing these, then you might want to consider it in its use.
Thank you very much. The next question, can you comment on the importance of B vitamins and L-glutamine as supplementary management of hypertension in our patients, and possibly how much they contribute to slowing down the progression?
So,
progression of hypertension-associated atherogenicity and possibly reversal of the same. This is coming from Kikumi.
Oh, Dr. Pia, is that one question?
Yes, it's one question.
Okay, so vitamins and glutamine supplementation have been proposed as possible support system really for slowing down reactive oxygen species and their progression of atherosclerosis. So they do have their place, but they are not a supplementation for antihypertensive therapy. Okay, so if the patient's BP is high, you're not going to treat the blood pressure by using B vitamins and L-glutamine. You need to put the patient on antihypertensive medications with evidence to support their efficacy. But yes, there is a place for these vitamins, especially the omega-3 fatty acids. They have a place in atherogenesis reversal, and that, of course, goes a long way to affect atherosclerosis and remodeling.
Thank you, Doc. So we know ARBs are more effective at reducing BP during sleep and wakefulness when they are taken at night. Does this not hold true for Telmisartan? And this is from Isaac Nyan.
Okay, so I'll give my take on this and then let the pharmacists also comment on the molecule that they've developed. But it is true that the ARBs had their effect, or most of them were recommended to be used in the evening. But Telmisartan has an extensive 24-hour coverage that does not really matter as far as when you take it is concerned, and it will be able to give you the coverage that you need. That's the other advantage that it carries. Stephen, any comments on that, please?
Yes, so I'd like to say, well, Telmisartan has very long plasma half-life. And actually, in a study which was done, where it was compared with Valsartan for patients who missed their dose after the first day, what happened was Telmisartan still continued to control blood pressure on the second day, even though there was a missed dose. So what we are saying is for patients who are going to be on Telmisartan or Micardis, what they can have is sustained blood pressure control for at least 24 hours, and that is very much assured in terms of how long your patients can be well controlled. So yes, just as you said, very good control with Telmisartan.
Thank you. Next question. Is Telmisartan's time-dependent efficacy a class-related feature characteristic of all ARBs, or is specific only to Telmisartan?
No, I'm thinking we are very aware that the ARBs have their effect. Once you are able to inhibit angiotensin 2, you will have an effect. But the special thing about Telmisartan is what Pharmaceutical said, that it has a very long time of action and therefore offers better control over a longer period than some of them which are relatively shorter acting and therefore will leave you exposed in the late periods of the night and in the early mornings when you're going to experience the surge. And that really is the bedrock of the efficacy that Telmisartan offers.
Thank you. Is Farm going to add anything to it, Farm Steven?
So basically, as I said earlier,
Ah.
you are short of at least 24 hours blood pressure control with Telmisartan. In the morning hours and evening, basically all periods of the day, your patients will be well controlled in terms of blood pressure. So you are well covered.
Thank you. Dr. Abba mentioned starting a grade 2, grade 3 patient on a drug therapy, preferably combination single pill. Which Telmisartan options do we have on the market?
So let me answer this. So as I stated in my short presentation, we have, apart from the monotherapy, we have the combination with hydrochlorothiazide, and we have the combination with amlodipine, which is 80 milligram, and the 5 milligram amlodipine, and the 80 milligram and 10 milligram amlodipine. With the combination with hydrochlorothiazide, the hydrochlorothiazide is fixed at 12.5, where the Telmisartan varies at 40 and 80 milligram, respectively. So that's the co-Micardis, and the combination with amlodipine is called Twinstar.
Thank you, Farm Steven. What can be done for hypertensive patients on medications who report with erectile dysfunction? This is coming from Fusu Mensayao.
Okay, so for Sumens, I think that's a valid question. Like I said, the antihypertensive therapies that we use are not without their side effects. And the first thing you want to do is to make sure that you educate your patient on these and you offer him the hope that if he experiences any of these side effects and he comes in, these are largely reversible when once the drug is stopped. But I'd like to caution here that the biggest risk factor for erectile dysfunction is not the antihypertensive therapy. It is indeed the disease itself, which is hypertension, it's the diabetes, it's the dyslipidemia, and which actually lead to these erectile problems. And the patient must understand that the effect of the disease process itself is probably more worrying than the possible side effect that may occur. So that we won't always blame all of these on the drugs. We must understand that it is also part of the disease process, must be seen as such. But nevertheless, it is something we should consider.
Okay, thank you, Doc. This is a very important issue for all of us.
I tell you.
The next question, please, can you use ACE inhibitor in a patient with bilateral renal stenosis? And it's coming from Abdullah Mariama.
Okay, so generally it is a clear contraindication. The mechanism, the ACE inhibitors work by causing, the renal glomerulus has an afferent and an efferent arm. And the ACE inhibitors work by causing afferent vasodilatation whilst maintaining efferent vasoconstriction so that you can maintain glomerular filtration within the Bowman's capsule. But when you have a patient with bilateral renal artery stenosis and you give ACE and it causes vasodilatation across board, then there will be no intraglomerular pressure to maintain filtration. The patient's creatinine will shoot up into the roof. And this is even worse when both kidneys are already stenosed. You already have a reduced flow into the kidney. And so this is a no-no. It's a contraindication.
No. Thank you, Doc. Okay. I think we've answered this, but let me ask again. Does Telmisartan have an advantage over AC inhibitor like perindopril? This is also coming from Mariama Abdullahi.
Okay, so I'll say my bit and then I'll let Mr. Colley also come in. Perindopril is an ACE inhibitor. The main advantage really of the ARBs over the ACE is the side effect profile. I think that when it comes to efficacy, generally they're both efficacious, but it's the side effect profile that adds that edge to the angiotensin 2 receptor inhibitors. So I think that's what I'm not aware of any head-to-head studies between Telmisartan in particular and perindopril. Mr. Collier, I don't know whether you've seen any.
Yes, so actually we do have one head-to-head study with perindopril, and the study showed Telmisartan reduces blood pressure a bit more compared to perindopril. Unfortunately, I don't think it's something I can project at the moment, but I should find the name of the study before the end of the presentation, and I'll get back to Dr. Abdullahi and everyone on the name of the study, and I'll put it up right away. Thank you.
Thank you for that. The next question, can Telmisartan be used as first-line therapy? This is coming from Yalfusu Mensah.
Okay, so in choosing antihypertensives for your patient, like I said, it's very important to look at the patient holistically and to see what they're actually presenting with. Now, most of the time, for straight Black patients who don't have any complications at all, then the recommendation would typically be first line for a calcium channel blocker or a thiazide-like diuretic. That is, if they have no other associated comorbidities. But once they have a high risk or a high grade of hypertension and you need to start 2 antihypertensives, then it is recommended that there should be an ACE or an ARB in the mix, and Telmisartan would actually come in highly recommended as a good add-on to the usual. The other thing would be that the ACE and ARBs and Telmisartan by extension has a place that nobody can take in certain disease conditions in the cardiovascular continuum. So if your patient has LVH, the patient must be on one of these drugs. If the patient is in heart failure, the patient has had a stroke, the patient has had an MI. And once there's a complication outside of the hypertension, the patient should be on a RAS inhibiting drug, and Telmisartan comes in highly recommended.
Thank you. Is it advisable to take one's daily medications in the evening to address morning surge? Any contraindications to this? This is coming from Maldwin Answer. Doc.
All right. So, ideally, because antihypertensives are usually administered once daily, it should ensure by its nature that its pharmacokinetics allow it to cover the patient's BP for 24 hours. And unfortunately, a few of the antihypertensives fall short in that department. But if you are thinking about the morning surge, you forget that also the patient during the day is going to work, is running around, is fighting here, is arguing here, and the BPs are likely to shoot up. So if you're putting it as an evening dosing and hoping that it will take care of the morning surge, but around 1 a.m., 1 in the afternoon, the patient gets stressed and BP shoots up and there's no cover, then what happens? I think the most important thing is to get an antihypertensive drug that offers you an actual 24-hour cover. Then it shouldn't matter when you take it, you are covered.
So I also like to say one thing. So just as Dr. Forstner stated, if this is really a big concern for a lot of your patients, again, reduces blood pressure in the early morning hours more than any other ARB currently on the market. And in terms of full 24-hour coverage of blood pressure reduction and please, I hope you can hear me.
Yes, we lost you for a brief second. But kindly continue.
Please, I hope you can hear me. I think the line went off for a minute.
Yes, we can hear you now. Can
Cool.
you hear?
So also, yes, thank you. Also, the name of the study which compared myocarditis to perindopril is called the Everest study. It's spelled EVERESTE. So in capital letters, it's a comparative study, and you can go ahead and double check. Thank you.
Thank you. Nino Christos says, great presentation, boss.
Thank you, George.
Question: how does the half-life of telmisartan directly impact the BP control as against that control achieved by valsartan?
I think that telmisartan has a longer half-life, and so it stays longer, it works for longer, and it is more forgiving in case you miss a dose compared to valsartan, whose half-life is much shorter and less forgiving.
Okay, thank you, Doc. I have a patient who is controlled on valsartan but suffered a mild stroke in the past year. Would you advise I switch to telmisartan for cardiovascular protection? Abba.
Okay, so so before that, I'm talking from my standpoint as a clinician. When your patient is on optimal or medication and develops an end organ damage, beyond blood pressures, you need, like I said earlier on, to look at the patient holistically. Was everything else controlled? Was the patient compliant? While the patient was on the valsartan, was the BP controlled? Was the patient sugar controlled? The patient dyslipidemic? All these checks and balances determine or influence the development of these end organ damages. So before you switch a drug, from a clinician's point of view, you must look at your patient holistically. Otherwise, when you put the patient on telmisartan and the sugar is not controlled, they probably will get another CVA. Okay, so look at the patient holistically. But as far as the blood pressure is concerned, then you need to make sure that your valsartan was actually doing what it was supposed to do. And then you want to consider a switch if need be. Because, like I said, the evidence has been proven for telmisartan and its cardiovascular protection because of its half-life. But as a clinician, look beyond the numbers. Look at the patient holistically.
Okay, thank you for that. What is your take on the use of CCB and diuretic combinations by most prescribers in view of the ESC guidelines that recommend use of AC inhibitors, ARB plus CCB or diuretics?
Thank you for that question. I mean, I think you've asked a question that I've been seeking an audience to address. Like I said, we are Black people, and most of the people we see are Black people. In fact, remains that we don't secrete as much renin as the Caucasians. And so the impact of the ACE and ARB in them is probably greater than it is in us. But most definitely, the benefit that we derive from the drugs is not negligible. So if you need to put a patient on 2 drugs, there must be an ACE or ARB or a RAS inhibiting drug in the mix. And that is guideline recommended.
Okay, Doc. Next question. Is there any risk associated with, in pursuit of long-term BP reduction, acute rise in BPs that can result in a cardiovascular event? And this is coming from Dr. Sewa Bunsu.
All right. So you are getting into the issues of blood pressure variability, and that's talking about how varied your blood pressure is throughout the day. Your blood pressure, even though it's not a static value, fluctuates, but within a limit. But some people's blood pressure shoot from 120/80 to 140/90 to 110/70, and that's called blood pressure variability. And patients who have an increased blood pressure variability have an increased cardiovascular risk. So, yes, it is important to watch um, patients' blood pressure variability when you are managing them on medications. And the ambulatory blood pressure device helps to look at variability in their blood pressures and then choose medications that reduce blood pressure variability, because it is indeed a cardiovascular risk.
All right, thank you for that, Doc. Lifestyle modification is advised if there is no evidence of end organ damage in grade 1 hypertension. That would include exercise, cardio. That's the question.
Um, if I understand you right, then yes, exercise is an important part of lifestyle modification. Lifestyle modification covers salt, it covers fiber intake, it covers alcohol reduction, smoking cessation, and a requisite amount of exercise, at least more than 150 minutes per week. To maintain your blood pressure. Unfortunately, people are not able to do this in a way that is able to keep the BP control. So invariably, a lot of people end up requiring pharmacotherapy.
All right, Doc. Thank you. For a patient already on a different ARB, how do you switch? This is coming from Kwashi Emmanuel Anam.
Mr. Colley, would you answer that?
Uh, what I would say is for most of the patients, for most of the ARBs, they are divided into two doses, the low and the high dose. For if your patient is say on a low dose monotherapy, say for ARB1, and you want to switch to ARB2, I would advise that you switch to the equivalent low dose of ARB2 before, and assess the blood pressure control before you try to increase to a higher dosage. So that will be the first point. So say if patient is on low Saturn, 50 milligram, and you want to start Telmisartan. Best to start with Telmisartan 40 milligram and assess the blood pressure control and the tolerability before. And if there's a need for an increase in blood pressure, if there's the need for an increase in the dose, then you may go ahead and do that then. Thank you.
Thank you. Next question. Does the fact that some patients have an early morning surge in blood pressure influence the time they should take the antihypertensive? It's coming from Leucy George Selao. Doc.
George, you need to identify a drug that gives you 24-hour coverage. You won't need to worry about that. I think that is the first condition you need to satisfy. You need to make sure also in our era that the molecule they are actually swallowing is what you think they are swallowing, and it's not an adulterated form of itself. So the brand must be looked at, the source of it must be looked at, because all of these things beyond the molecule itself affect how well it works. If you choose um, between one molecule, two different brands, uh, depending on what brand it is, the effects are different. But after that, you should ensure that the drug has 24-hour coverage, and that should take care of your early morning surge. Then you won't have to worry about the early morning surge.
Okay, well noted. Is telmisartan safe at all EGFR levels, or it has a limit, which it shouldn't be considered? Aqua Michael Kwejo is asking this.
So Telmisartan is excreted via the kidney at around 1%. So when Dr. Folsom was presenting, she did mention that it's quite safe. It's quite safe in terms of the kidney, but you still need to be careful for your patients who might have very low EGFR levels. So even though the majority of the excretion is not via the kidney, it's via the GIT, you may still need to be careful and assess the patients in terms of the patient's EGFR levels and also potassium levels. But then when you compare to other ARBs, it offers you much better because those ARBs are majorly excreted by the kidney. So at least for levels where certain ARBs cannot go, telmisartan can give you more, but then you still need to assess your patients during this period.
Very well said. Thank you. AC inhibitors or ARBs, which of them has better mortality and morbidity prevention profile? Perindopril or telmisartan? This is coming from Atakli Maxwell Kwesi.
So, Dr. Paulson's presentation, she did mention that the ACE inhibitors and ARBs are mostly alike in terms of the mortality and morbidity, except the ARBs gives you, much more um, in terms of tolerability, and the patient tend to stay much longer on ARBs. So that's a good thing since we have issues with um, compliance. So ARBs tend to give you more compliant patients. Now, again, I stated that there exists a head-to-head study between telmisartan and perindopril, which is called the Everest study, EVERESTE, and it shows telmisartan as an edge in terms of blood pressure control over perindopril. You also have to know telmisartan compared to the gold standard, the Ramipril, which in terms of CV protection showed its ability to reduce strokes, MIs, and basically cardiovascular death, as you would expect from patients who are on Ramipril. But in terms of blood pressure control, you tend to get a bit more with telmisartan as compared to perindopril.
Okay, thank you for that answer. What is your take? I think we answered this one. Next question, please. Albert Azumache says, amazing work. Thank you, Albert. I think that is the last of the questions. So now I'd like to say a very big thank you to our facilitators, Dr. Alba Folson and Farm Stephen Colley. You've been very helpful. You've done justice to the topic for today. I would like to say a big thank you to Boehringer Ingelheim. Stephen Colley, am I saying it correctly?
So
Yes,
it's
that was
Boehringer Ingelheim. So
Ingelheim. Yes,
yeah,
thank you
it
so
takes
much
time.
to International Maritime Hospital for sponsoring this. We would like to thank you all for participating in it. And then we'd like to thank CES for hosting this for all of us. I think after, if you still have questions, you can still put it up on the platform, and in time, the facilitators will answer for all of us. Any final words for us? Otherwise, we'll call it an afternoon.
No, I've got none.
Thank you, Dr. Fosen.
I think look at your hypertensive patients holistically. Look at them in totality and then offer them the best therapies. Yeah, thank you.
Thank you. We'll look at them in totality. Thank you so much. And I wish you all a very good evening. We'll see you again soon. Have a great evening. Bye.
Thank you. Bye bye. you.